Good morning and good afternoon, everyone. My name's Beth Bradford, and I'm a Senior Technical Advisor for Family Strengthening for the Project Coordinating Comprehensive Care for Children, also known as For Children. Really glad that you could all join us. It looks like we have about 36 participants, which is just wonderful. So welcome you to the Integrating Early Childhood Development Interventions into HIV Clinical Care webinar. I would like to start just by welcoming everyone and thank you for joining us. Today's webinar is organized by For Children and being hosted by ovcsupport.org. The presentations today we really hope will bring us firsthand experience from programs in Rwanda, Eswatini, Lesotho, and Malawi that are working on integrating early childhood development, or ECD, into the clinical care setting. Today's webinar will be a virtual panel presentation followed by a discussion period to address your comments and questions and the program areas that you would like to hear more about. We're really hoping to get to that discussion period again so that we can hear what aspects of early childhood development and integration you'd like to hear more on. Throughout the webinar, you can use the messaging area or tool to share your thoughts or questions. That's with the chat boxes, which will appear on the left-hand side of your screen. We'll make note of those questions and points for the discussion period. You can address them to any of the speakers today. The session is being recorded and it will be posted along with the presentation on ovcsupport.org after today's event. Just very, very briefly to get us started, I know there's a lot of information on this slide, but just to kind of set the tone, we wanted to have you be considering the effects and impacts of HIV during this important early childhood period. To frame that, just a couple of points that I'd like to highlight. One is that millions of children under 5 in low and middle income countries are failing to reach physical, cognitive, linguistic, and social emotional potential. For children, for infants who are living with HIV or those exposed to HIV, there have been found to be significant risks to mental and motor delays during the first 2 years of life. And we know that the important linkages between health and other aspects of early childhood, such as stimulation and early education, are critically important to having a good start. As well as any impacts on early childhood, negative impacts, really have implications for throughout life on educational attainment, on physical and mental health, on a child and adult's ability to connect socially with their community, and certainly on economic participation. So just to highlight again the importance of this period and why For Children and our partners felt that it would be really useful to hear about what's happening around early childhood development and HIV. So just next to further frame this discussion, I'd like to introduce Dr. Lucy Kluber, Professor of Child and Family Social Work from Oxford University. Dr. Kluber, can you begin just by briefly telling us more about why introducing ECD into clinical care is important? What do you think the advantages are?
Oh, well, thank you, Beth. And just to frame the discussion that's coming with our two program specialists, I'm going to share a bit of the latest evidence base for this and a bit of overall thinking. If we move to the next slide. Great. So many of you will be familiar with the new WHO Nurturing Care Framework, which is a really exciting new initiative that's helping us think about the importance of early childhood development and its components. And you'll see what's important about this. And if you move to the next slide as well, you'll see that health is seen as a fully integrated part of joining with nutrition, with parenting, with safety and security and learning opportunities. And so I think we're moving conceptually at the highest level with the World Health Organization. And this has really been led by Linda Richter, Mark Tomlinson and Bernadette Delmans, as well as people like Nigel Rollins. But really a conceptualization that at this stage in childhood, we can't be separating them out. So if you move to the next slide, we also, I mean, there's a sort of obvious and initial question, which is why not? Why are we not already seeing integration of ECD into HIV, particularly HIV and general early childhood healthcare? Well, some of the reasons that come up in the literature are the deep divisions between the healthcare systems and the social welfare or education systems, where ECD is more commonly situated. And these come through at every level. They come through at the practitioner level, where nurses are not necessarily directly connected with schools or early childhood development centres. They come through at the funding level, with both government funding streams channeling through different ministries, but also through NGOs and funders who are interested in funding either health or ECD. We also see a lot of talk about time shortages of healthcare staff, particularly as a challenge to making effective and following up on referrals. And generally a sort of limited capacity for referral networks. And that's not totally simple. It's not just about the limited capacity of the healthcare provider or the ECD provider to make and follow up referrals. It's also about the limited capacity of, say, a young mother with very little transport money to reach multiple different sectors. And finally, probably one of the reasons is a lack of understanding of the growing evidence base demonstrating the value of combining the two. And if you move to the next slide, we'll have a look at just some examples of this, all from sub-Saharan Africa. So we're seeing a number of really exciting randomized control trials, a cluster RCT in Malawi and a multi-center cohort study in South Africa done by the Ketempilo folk, find lower rates of child mortality, lower maternal mortality, higher viral suppression, and increased retention in ART. If you look at the odds ratios, you can see that these are substantial effects. If we move to the next slide, we can see that more and more studies are beginning to show this. The latest one came out only a couple of months ago. But what we see is not only better engagement in HIV care, but improved breastfeeding practices, particularly important when mom's HIV positive, but important for all children, and increased other developmental things like height for weight, Z scores. If we move on to the next slide, there's also 3 exciting new studies which are going to be coming out within the next year, and these are funded by USAID as part of a special initiative. This study is being done in Zimbabwe, led by Francis Cowan and colleagues, and Lorraine Scher. This is and all of these studies are integrating ECD, economic strengthening, and HIV care. If you move to the next slide, we'll see exciting M2M is involved in this trial in Swaziland. And to the next slide. And this study led by colleagues at University of Stellenbosch and UCL, looking at integration of HIV care into ECD centres. So in a sense, the other way around in Lesotho. So this is just flagging up 3 exciting new trials in difficult contexts, which are going to be coming out soon. So if we move to my, I think, last slide. Just as a real conclusion, there is a growing evidence base, but that evidence base is conclusive. It's telling us that if we can combine clinical care and ECD care, we will get better outcomes for both mothers and children. And so really what we're going to on next is the exciting practical examples of how this can work. And so first I'm going to introduce, and I'm delighted to introduce, Fiona Burt, who's a senior technical advisor for early childhood development with Mothers to Mothers in South Africa. Mothers to Mothers is really recognized as a leader in developing non-clinical complementary PMCCD and ECD services across sub-Saharan Africa. They've been using a peer approach to address maternal and child health, nutrition, early learning and parenting through programs in Swaziland, South Africa, Lesotho and Malawi. So Fiona, over to you, and what we'd like to hear about is the strategies that Mothers to Mothers is taking to improve integration of ECD in clinical care, and particularly in relation to mothers living with HIV. Thank you, Fiona.
Thanks very much, Lucy. So if we can go to the next slide. For the past 16 years, Mothers to Mothers has been implementing a peer mentorship model, as Lucy mentioned, in Southern and East Africa. It started as a PMTCT intervention, and we've since expanded it to become a broader maternal and child health approach, with our cadres of community health workers known as mentor mothers based in public health facilities in the surrounding communities. This approach of deploying HIV positive mothers themselves as peer mentors within the public health service has helped M2M contribute to much lower rates of mother-to-child transmission of HIV among our clients. But really recognizing the need to move beyond survival to ensuring that young children thrive, since 2015 we've expanded our services again to include early childhood development. In Eswatini, formerly Swaziland, Lesotho and South Africa, we've delivered a complementary ECD program alongside and linked to our existing PMTCT and maternal child health intervention in facilities and communities. And through this, we've observed high rates of key outcomes such as developmental milestone achievements and maternal coping, and even lower rates of HIV transmission. But from this year, we've begun to be able to adapt our approach to achieve wider coverage by ensuring that all our clients, antenatal and postnatal, are given some level of ECD education, information and support. So our first implementation country for this revised approach is Malawi, where we've just started to implement in Malanje district, which has the highest HIV burden in the country. So now, rather than deploying specific ECD mentor mothers working alongside our facility-based and community-based mentor mothers, we're using a different strategy by training and supervising our existing cadres, the facility and community staff, to add education and support to their work. If we can go to the next slide. So our focus is now the period from pregnancy up to children aged 3, recognizing this as the most critical period of early development, working at facility, community and household levels to ensure that parents, caregivers and the broader family understand more about early development and how to create an enabling environment for their infant's development. Our strategy for our integrated ECD approach is four-pronged. So it's mentor-mother, M2M's mentor-mother support at health facilities, community-based parenting groups for both antenatal and postnatal clients, high-intensity case management through regular household visits, and a process of referrals and linkages to facility and other services. We know that there are some clients who are particularly vulnerable and need all of this support, and of course there are those who are doing well and need less support. We're also very cognizant of the fact that resource limitations mean we won't be able to reach every household in a community with every service, but we do want to ensure that we touch every client we see with some level of ECD, at the very least with key messages about nurturing and responsive care, brain development, early learning stimulation and nutrition, as well of course as health and HIV messages. Our main enrollment point for clients is the local health facility, and our mentor mothers are trained to use a simple risk assessment tool to assess the vulnerability of all new antenatal or postnatal clients. Then, once the client has been assessed, she'll be invited to join one of 2 community-based streams. Everyone basically is invited to participate in monthly parenting groups. They're either antenatal groups or postnatal groups, and we call them parent information playgroup sessions, or PIPs, because they use a multi-layered strategy. So on the one hand, they offer clients facilitated information, while also being an opportunity for peer sharing. And this combination approach is something that our clients seem to value hugely. They receive what they consider to be trusted, informed messages from the mentor mother facilitators, while also themselves being able to just share and discuss practical issues with fellow mums or pregnant women. At the same time as the adult group is happening, their young children are able to participate in a facilitated play session with age-appropriate toys and games. So this is not, hopefully, it's not only fun for the children, but we try to ensure that the play group is actually within sight of the adults, as it's a chance for mothers and caregivers to observe play practices and for conversation to be stimulated about the importance of play in child development. And we think that it's absolutely critical that there's an element of that. That's kind of one of the key parts of the what we like to call the ECD-ification of our maternal and child health kind of interventions. So the second stream, which is focusing, as you see at the bottom of the screen on the left, there's a high risk mentioned. The high-risk stream involves adding to the PIPs and the continuing facility-based services with a program of monthly household visits, whereby community mentor mothers open a case management file, or in this case, they're using a specially developed mobile health application to create a detailed client and household profile, update key information regularly, track indicators, and do specified activities, including quarterly developmental milestone assessments. Clients can also be enrolled at community level, if you see on the right, through a process of, we don't do door-to-door interactions to try and identify clients, but we do have processes of community mapping, and then we may be referred by clients to neighbours who may need to be assessed for services. And then even at household level, we may enrol people so that in households with multiple clients or potential clients, who are related to or living with the index client, it may be necessary to enroll a client through the household. And then if we can move on to the next slide. So with this project, always as the basis of our programming is, the foundation of it is HIV related. So HIV is always a critical component when we're assessing and considering vulnerability, but there are other vulnerabilities that we're looking at. And what you see here is actually something that we worked on with our team in Malawi to ensure that it was actually relevant and appropriate for the context in which we're working in Malanje district in Malawi. So you'll see the darker yellow boxes are those that we're prioritizing, but others around the circle are also important, of course. So critically, we're focusing on HIV positive children, age 0 to 3, HIV exposed infants, 0 to 3 age children with another HIV positive caregiver, or with children with poor nutritional status or stunting, who were premature or low birth weight, those who may have a disability, are orphaned or abandoned, and very specific to Malawi is the need to do specific targeted interventions with very young mothers. So what we have understood more and more and more is the importance of being able to differentiate care and offer targeted services. So it's one of the reasons why we're not aiming to deliver everything to everybody. But we are always making sure that we are linking our clients to HIV services, whether that's prevention, obviously in the case of negative women or children, or ensuring that those who are HIV positive are involved in the HIV care and treatment programs, and that they're being given ongoing support as they're considered high-risk clients. Thank you.
I was muted. Sorry, everyone. Thank you, Fiona, for sharing this really exciting program. You know, and it's fantastic to see what M2M are not just thinking about, but actually doing. So I've got one follow-up question, which is that we know that Mothers to Mothers work very much in partnership with others, but do you have some more general thoughts about how we can work better in partnerships?
Yes. Well, it sounds completely obvious, but the starting point really is to recognise the importance of partnerships for integrated ECD interventions, and then always to include a strategic focus on developing partnerships in programme planning and also with ongoing implementation. So we know that our work is only made possible by working in partnership with numerous stakeholders, and critically this starts with families themselves. So we've moved purposefully to taking a family-centred approach, and you can see the diagram on the screen now indicates this, to most effectively create an enabling environment for reducing HIV transmission and increasing positive child health and development. For M2M, therefore, an integral requirement for achieving impact is the relationship of trust built between the mental mother and her clients, and that includes all members of a household. Then it's important to have a sense of partnership with the communities in which we work. And to help facilitate this, one of our key criteria for recruitment of mentor mothers is that each mentor mother should actually come from the community in which she works. So she's known and she understands that community, and she's much more likely to be trusted than if she were an outsider. And strong partnerships with clinical partners are also a prerequisite for successfully integrating ECD into HIV interventions. And so our mentor mothers work hand in hand with and are hugely valued by the healthcare workers at public health facilities. With this new integrated ECD RMNCH approach, we're even more purposefully aiming to strengthen the health system. And I like to talk about infusing it with ECD. I don't want anyone to get away without having been touched by ECD. So our partnership extends to including healthcare workers and community health worker cadres in ECD training, and working towards identifying and working closely with ECD focal people at facilities particularly. And that's really helped by having built strong partnerships over time with the Ministries of Health. By seeing our work and its impact for themselves, health officials understand the added value that mentor mothers bring to PMTCT and maternal and child health services. And we're finding that they're really excited by the potential for improving child health and development outcomes and creating more child-friendly services at health facilities through integrating ECD into the work. An absolutely indispensable way we've found over the years to make progress in working in partnership with government is to understand the key performance areas of a district or of a particular role, and then demonstrate how our efforts can actually assist them to achieve their KPAs. And as ECD is quintessentially holistic and necessitates a multi-sectoral approach, partnerships with other key ministries, the lead ECD ministries in any country, of course, if that's not the Ministry of Health, multilaterals such as UNICEF and civil society partners are absolutely vital. We want to ensure that our ECD clients receive the holistic package of care indicated by the Global Nurturing Care Framework, but we know we can't do everything ourselves. So we look for pathways to linkages and referrals to other services, as well as opportunities to collaborate. So we aim to build a mapping component into every project we do, mapping services and potential partners in the communities and districts where we're working, both as a project startup activity and as an ongoing aspect of the work of our community-based staff. Finally, what we know absolutely is that having supportive, partnership-minded funders who understand the advantages of collaboration and sharing between grantee partners is a huge bonus. The primary support for our integrated ECD and health intervention in Malawi comes from the Conrad N. Hilton Foundation, and I really want to appreciate the Foundation's generous focus on stimulating and supporting partnerships, which has helped us to work towards effective integration of ECD into HIV interventions. So it's those kind of partnerships, Lucy, that we're looking at. There are many more, of course, but I think it's the bottom line is we cannot do, or no one can really do, an effective community-based ECD intervention, particularly when it's integrated with HIV care services, without having a strong focus on partnership.
Well, thank you, Fiona. That was brilliant. And as a reminder to everyone listening, please do feel free to write comments about your experience or questions in the chat box, and we'll collect them for the discussion at the end. And now we're going to talk with Catherine Kirk, who's the Director of Maternal and Child Health for Partners in Health in Rwanda. Partners in Health supports the Rwandan Ministry of Health in operating a paediatric development clinic model, an integrated model providing medical, nutritional and developmental follow-up for high-risk infants. We're really happy to have Catherine sharing with us today about the strategies and opportunities that she sees for improved integration in Rwanda. Catherine, can you tell us especially how we can move from surviving to thriving with ECD and HIV care?
Thank you, Lucy. It's a pleasure to share with you all about the Pediatric Development Clinic, which was developed jointly by the Rwandan Ministry of Health and Partners in Health in Rwanda with support from UNICEF and Grand Challenges Canada. Next slide. Partners in Health works with ministries of health all over the world on efforts to strengthen health systems. And one of our priority areas of intervention in Rwanda for many years has been around neonatal care at the facility level. And Lucy laid out very nicely all of the rationale for how important it is to integrate child development into the health sector. And we saw a key opportunity in Rwanda where we were making great advances in newborn survival, but we know from evidence everywhere else in the world that we must provide ongoing care to ensure these children with different vulnerabilities that result in hospitalization in the newborn period are able to reach their health and developmental potential. Next slide. In our own context in Rwanda, we looked at a particular population of preterm and low birth weight who are a focal population as well within the nurturing care framework. And we saw rates of malnutrition that were double or triple the rates in other rural communities of Rwanda when children were 1 to 3 years old. And we saw very high rates of failure on developmental screening assessments. So this provided justification for us in the Ministry of Health to develop a pediatric development clinic model that's integrated within the Ministry of Health system to deliver clinical, nutritional, and developmental care. Next slide. The Pediatric Development Clinic functions in the public health system using existing Ministry of Health staff. The team is made up of nurses, general social workers, and receives oversight from a general practitioner at the level of a district hospital. Next slide. Our focal population for this clinic is based on a unique population that has various needs in terms of medical and clinical care, such as children with birth asphyxia and prematurity. Children need nutrition and growth monitoring and intervention for those who are experiencing growth failure, responsive care in terms of play and stimulation, and additional social support as needed. So as you can see within our populations, we are working within the eastern portion of Rwanda right now in a total of 7 clinics. We focus first on primary population discharged from hospital neonatal units, prematurity, low birth weight, asphyxia, and also have another secondary cohort of children who are referred many times from the health sector, either outpatient health clinics, pediatric wards, emergency rooms, and sometimes for the community with various conditions that warrant follow-up. We have not in Rwanda specifically targeted HIV-exposed infants or HIV-positive infants as a condition of enrollment because the system for PMTC Take Care is slightly separated. And so we focused on the population of children who had no medical home for follow-up. And to date, in just 4 years of operation, we've enrolled over 1,500 children in these 7 clinics. Next slide. Within the clinic, I told you we have a staff of the nurse and the social workers, the primary staff. What happens is the clinics operate once per week, and children are followed up based on their condition and their current status. So more frequently when they are very young, and less frequently up until 2 years of age, at which point they're discharged if they are doing well, and can continue follow-up up to 5 years if they have ongoing issues. The weekly visit starts with a group counseling session, most often led by the social worker, which facilitates discussion around health, nutrition, and development topics in a child-friendly environment, providing opportunities for play for the children and specifically coaching caregivers on how to play and interact with their children. Each child is then seen with their caregiver in a nurse consultation where they undergo a clinical screening, their nutritional screening, and then receive individualized developmental monitoring and responsive care feedback on the importance of play and stimulation. For caregivers requiring additional support or children who are having complex issues, particularly around malnutrition or family environment challenges such as gender-based violence or interfamily conflict, there is an individual social worker consultation, at which point they provide additional counseling, can schedule home visits if warranted, and provide a small package of social support for those who need, such as transport reimbursement or nutritional support in the form of food packages. Next slide. I wanted to share a little bit about the experience we've had and what we've learned in these past 4 years as well in implementing this model. So if we go to the next slide, one of the values we've heard from mothers particular is that the Pediatric Development Clinic has created a space where they are able to come together with other mothers who are in a common situation as them, so mothers who are have children with various developmental disabilities, and having that space to be together with peers and share and learn from one another has helped to reduce the stigma of having a child who has special needs. In addition, caregivers have appreciated learning about the importance of play and interaction and increasing their understanding of how important it is and to provide stimulation in a positive environment, and that learning starts from birth. Next slide. One of the major challenges experienced by the clinic population that we see is really high levels of malnutrition. And when I started, I mentioned children in the absence of care had rates of malnutrition double or triple the national levels. What we're seeing among those same populations who are being followed in the clinic are much lower rates of malnutrition, but still elevated beyond what we would expect of the general population, highlighting both the impact of the clinic, but the immense need for this clinic to support these children's cognitive and nutritional development. Next slide. As we are working directly within the health sector, there are different challenges we have experienced in implementation. One is that because we are operating in the clinical setting with direct healthcare providers from the Ministry of Health, we have a barrier in the sense that children's health in Rwanda is really viewed as the responsibility of mothers, and it is uncommon to see fathers or men really bringing their children to the clinic, which means we do not have the type of father engagement in the clinical care setting that we would like to see. The introduction of developmental care into the clinic setting is also something that is new for these healthcare workers, and clinical staff tend to be slightly less comfortable with those aspects of play coaching and early stimulation. And of course, barriers for quality assessment of how children are progressing within the clinics in Rwanda due to lack of specific tools for our context. And in teaching these skills for both the clinical, nutritional, and developmental care for these children, we find that there's a really intensive need for ongoing mentorship and training of the providers to ensure that they're able to apply the care protocols to identify problems early and provide appropriate intervention. And of course, there are also gaps that happen in the home setting. Particularly, we see this around feeding in the general home environment, and challenges that caregivers experience when they go home trying to implement the high-risk children experiencing developmental delays who may have difficulties feeding for various reasons. Next slide. Despite these challenges, we have found that really there's an incredible opportunity and that it is feasible to work with the existing healthcare staff and system to provide early childhood development care in a holistic way that is envisioned by the Nurture and Care framework. This, of course, requires ongoing support for improving the quality of the services and strengthening the services provided, and making sure that child development responsive care is being equal as clinical care to traditional healthcare providers. And as Lucy highlighted as she was starting, there's an immense need certainly to strengthen referral systems to higher levels of care for children with advanced needs. Next slide. Just want to say thank you for everyone's time and attention.
Well, thank you, Catherine. That was really exciting to see how it's happening in one particular country. And just quickly a follow-up question. What opportunities do you see for even more improvement of integration of ECD into clinical care?
Thanks, Lucy, for that great question. I think one of the most important things that we all need to do is work on advocacy at the national and subnational levels, particularly to ministries of health, to elevate the understanding on the close linkages between ECD, as it is traditionally described, and of course the health sector, which is health being an ultimate pillar of child development. We have an immense opportunity with global frameworks just recently released in Nurture and Care, and of course SDGs around early childhood development that I think create a prime opportunity to really push this advocacy forward and bring together the Ministry of Health with the more traditional ECD stakeholders within social welfare or education systems. And I think it is an easy sell if we're able to articulate this message and make sure we are really putting it out there in terms of advocacy at national and subnational levels. And with that, I'd like to hand it back to Beth for the discussion. Thank you so much.
Thanks so much, Kat, for taking us through some of the strategies that Partners for Health has been using, and also for those ideas on where we need, what work we need to be doing to further integration. Just also a huge thank you to Fiona and Lucy. It's been incredibly interesting, as I think we can all attest, and we can see by the various questions coming in. Really helpful to hear the on-the-ground experience. We have some time left for discussion. I see that there are already a lot of comments and questions in the chat box. But if you do have something that you'd like to hear more about, feel free to type anything in there now. And just before we move, if we could move to the next slide, please. Thank you. Just before we move to your questions, we just wanted to let you know to please watch this this space on ovcsupport.org for the For Children literature review and discussion paper on integration of early childhood development in clinical care, which is coming very soon. And also on your screen, you'll see reference to a new ECD resource page that Catholic Relief Services has just launched. And that includes links to all kinds of ECD publications, podcasts, stories, and videos. So let's go ahead to our first question. Again, I see a lot of interest on various topics coming in. Hopefully, be able to get to most of them. Maybe Fiona, over to you first with a couple of questions. The first one was around what are the core ECD domains that your vulnerability assessment tool is capturing for eligibility and enrollment? And then just to give you maybe two questions at a time, since the focus is on early stimulation and learning through play, the person asking is wondering about how you ensure some of the other components of the nurturing care are provided to caregivers and children.
That's great. Thank you very much, Beth. So what we're really assessing with vulnerability, I think you probably had asked that question before I moved on to the slide that showed some of the key vulnerabilities that we were looking at. So really, it's not about ECD domains so much. So in terms of ECD domains, we're definitely kind of supporting development of under the different domains: cognitive, physical, socio-emotional, and language domains, and we assess those as milestones the milestones for those every quarter. But the vulnerability assessment is about assessing clients, so whether it's the mother or the baby or young child aged up to 3 years. And as I showed there, it was really about their HIV status, their nutrition status, disability, and then key factors such as in Malawi, it's the youth of many mothers. On the question of the stimulation, is actually sorry, I didn't have time to fully explain what the model is, but it's really a holistic package. So it's not just about early learning stimulation, but that's a really important part of what we do, because I think it's the shift from being a focus on maternal and child health and on PMTCT and HIV care to expanding. And what we've looked long and hard and thought really hard about what are the key extra things that we need to do to make sure that we can truly say this is an ECD program, not just a health program. And that's why I think the importance, we know more and more and more about the science of early childhood development, the importance of brain development in the earliest years, including during pregnancy, about stimulating that through play, through all sorts of activities that you as a parent or a caregiver can do at home. So we are focusing on those, but also on nurturing care, obviously on things like nutrition as well, and all of the health issues. So what we are very aware that we're not doing so much of at the moment, but we do try and make sure there are linkages to things like household economic strengthening programs, given that the almost all of our clients are living in to some degree of poverty. So where possible, where there are services, this is why the mapping of services and ongoing mapping of services and stakeholders is so important, because we need to be able to link people to those, because we recognize that underlying basically everything that our clients are living with is the issue of poverty and inequality.
Thanks so much, Fiona. I think that that addressed actually any number of the questions that are coming in. Really appreciate that. Kat, can you give us some thoughts on efforts that are being made to transition from a project model to sort of sustainable health system approach that really creates conditions for scaling up? Somebody else was asking about, really how we can ensure that that projects like yours and Mothers to Mothers can be rolled out. And then, perhaps, I don't know, related to that, or a secondary question is any thoughts you have on how we can really involve caregivers at the early stages of a project's implementation, as well as healthcare staff and workers, because we know that oftentimes asking more of the workers who are health workers in particular, who are already doing so much, can be challenging and a key barriers.
Great, thanks for those questions. I'll start with the question around thinking about scale up. As I mentioned, we've been working really closely with the Ministry of Health on this model, and I would say these past 4 years, while it seems long, have been an immense period of learning about how to establish a chronic care platform specific for young children, and particularly young children with complex needs that are evolving over time, given the diversity of the population in the clinics. And what we've been doing as we go along is ongoing discussions with the Ministry of Health and other stakeholders about how this model can be expanded. And currently at the moment, there are efforts in Rwanda to take lessons learned from this experience and develop a national guidelines for follow-up care of these high-risk newborns. And so that for us is a starting point on taking kind of what do you think is the ideal package based on what we've been learning, and setting that as the national standard, and then trying to support facilities to implement that within their existing staff and space. One of the nice things is that by working with existing staff and not adding additional professions or roles, is that it means it is feasible for other clinics to integrate this program in the same way that they have integrated other services as they become increasingly available within Rwanda, such as non-communicable diseases, which is where we've actually housed kind of the implementation of the program from a ministry standpoint. And of course, I think one of the big things is we've been refining our tools that we are using for care delivery and training, so that they are prepared and easy to use for others. So it's an ongoing process, but we are hopeful that given the successes we've had to date, and also just the immense need, that we'll be able to move this forward at a national level, so that all children discharged from hospitals and neonatal units are able to receive this care. For the other question on involving caregivers, when developing the program, there was a lot of discussion and feedback, and we continue to do focus groups and things with the mothers engaged in the clinic, as well as the providers, to sort of understand better how we're meeting their needs and where gaps remain. I absolutely think it's critical to understand from the caregivers very early on about their kind of what they need. And I think something we are exploring now, and there was another question a bit about this, is if there are some components that maybe can be decentralized from the clinic to the community within existing structures as well. Part of trying to alleviate some of the responsibilities of the healthcare workers, because what we have seen is that there's huge demand for this program, and client volume is very high. And so what components might we be able to decentralize to share some of those responsibilities and leverage other activities that are happening more at the community level in Rwanda, particularly around peer support and even further kind of time and focus around parenting and early stimulation.
Thanks so much, Fiona. Definitely agree with a lot of those suggestions. I also am just reminded of something. I'm sorry, Kat. Thank you, Kat. I'm reminded of something that Fiona said earlier, which is just about when she was asked the question about partnerships. The first thing that she brings up is the importance of partnerships with families. So I think that is something of critical importance to remember. Lucy, I'm curious if you have thoughts. We had two questions, I would say sort of semi-related, and I'd love to hear your thoughts on these. One is about how we might better engage fathers and male caregivers in this work. We did hear, I think, a little bit from both Kat and Fiona about, perhaps where that might be challenging, but any thoughts you have. And then another question was just about strategies for engaging with schools and even with other kinds of other vulnerable groups when it comes to early childhood development. Any ideas or thoughts you have?
Absolutely. So the issue of fathers or male partners who may or may not be the fathers, or potentially grandfathers or uncles, we know that there's a range of potential male caregiver involvement that could be capitalized on. I think what we do have is fantastic evidence that where that can be encouraged and is successfully encouraged, it results in better maternal and child outcomes. However, the $54,000 question is, how do we do it? And from what I've seen, the evidence is really limited to small scale pilots and NGOs who are not necessarily able to measure the effectiveness of what they're doing. And so really what I would say is, in terms of building the evidence base on this, I would really urge anyone who is doing this kind of work to think about how you can evaluate it and use that to build up our general knowledge on how to do it. The question on how to work with schools is one that I think goes right up to the very top of thinking about ministries and how we can encourage integration starting at the most senior level. And there's been some fantastic work done by London School of Hygiene, economists there led by Charlotte Watts, on the concept of development synergies, with the idea that many sort of focus areas, and ECD is an absolutely fabulous example of this, although not the one that they've used, can have positive impacts across multiple ministries. They can improve outcomes for education, for health, for social development, and that we could use that kind of costing models to go back to ministries and persuade them to be able to do what's called bucket funding. Essentially everyone puts in a certain amount and you'll all get better outcomes because of it. So I think that's one really exciting new idea about how to do some of the important advocacy work that Kat was talking about. Back to you, folk.
Great suggestions. And I do see also in the chat window that Project Concern International is doing some work with Harvard looking at male engagement. So that's another resource for people. Maybe just a couple of last quick questions. Fiona, can you say just a sentence or two about the cost implications of implementing mother-to-mother groups? I would imagine that it's a cost-effective model, given that it's a peer-to-peer model, but anything that you would say just in a sentence or two about that?
It's a peer-to-peer model, but the peers, our peer mentors, the mentor mothers, are employees. So one of the the critical aspects of our program is that as an added value is the empowerment and the reduction in stigmatization of HIV positive mothers themselves. So since the get-go, Mothers to Mothers model has been about using HIV positive women not merely as stipended volunteers or non-stipended volunteers even, but as paid employees, so that they are gaining skills and experience. They're very professional in what they do, and they work full time. So in a sense, I mean, we have to have a caveat to this, that there is a cost to doing this kind of work, but where we've been seeing some great successes is by working the Mentor Mother program into the public health system, as we've been able to do in Kenya and to some extent in South Africa. And the Kenya Mentor Mother program is now fully owned by the Kenyan government. It doesn't at the moment include ECD particularly, but it's all about maternal child health and PMTCT. So ultimately, I know that everyone always wants us to get to the point where government is owning interventions, because that's the most sustainable way of doing it. But it's not always possible. So we have to always be wary of saying there's little cost involved, because there always is a need for funding and partnership as well, again, in order to make these happen.
Yeah, great points. Lucy, I don't know if you're able to type something into the chat window. There is someone asking for a link on the paper from London School on the bucket funding idea. If you are able to do that, I don't know if you can.
It won't let me, but
okay.
If you look up Michelle Remme, her surname is Remme, and the sort of original paper they wrote on it was in 2014, and it was published in AIDS. It's not called bucket funding, it's called something much cleverer than that, but you will find it if you look up Remme 2014 AIDS.
Great, thanks. Thanks for that. Just as a final question, really, over to anyone, I think we live in an age when we have vulnerable populations experiencing really all sorts of emergencies, a lot of people on the move, a lot of climate-related emergencies, et cetera, et cetera. And I just wonder if any of you have any final thoughts on how some of these ECD models or strategies can be utilized in emergency settings. And I know that's a huge topic, but again, just if anyone has a sentence or two to give us an idea on what's being done or what could be done. Fiona, well, Kat, yeah.
Just from me, I would recommend you have a look at what the International Rescue Committee are doing. Really exciting and innovative stuff, and really starting to think about how they can evaluate that most effectively in emergency settings.
I think another important place to be looking at is the newly inaugurated or inaugurating working group of the African Early Childhood Network, which is going to be focusing on children in relief situations and how best to implement interventions for them.
Great, thanks. Kat, anything you would add there?
No, I agree with what they've shared. It's certainly an important but challenging population to make sure we're reaching.
Great. Well, just before wrapping up then, again, with an effort to end on time here, I think this has been an incredibly insightful and useful presentation and really great questions which enhanced our discussion. I just want to appreciate very much Lucy, Fiona, and Kat for sharing your work with us today. I think it's really asking a lot sometimes for people to step away from their day-to-day work and take the time to share. But this kind of partnership and sharing of experiences is really important to moving ECD forward. If you'd like to share what you've heard, if you'd like to be able to look back at the presentation again, a recording of today's webinar will be posted on obcsupport.org within the next few days, and you'll be able to share it with others that way. And thank you to our 75 participants for being on the line and for listening to what we had to present. Thank you.
Wow.